Hello everyone, I hope you are doing well. Today I am going to talk about cholinergic agonists. As we know, drugs affecting the autonomic nervous system are divided into two groups according to the type of neurons involved in their mechanism of action. The cholinergic drugs act on the receptors that are activated by acetylcholine, whereas the adrenergic drugs act on the receptors stimulated by norepinephrine or epinephrine. Cholinergic and adrenergic drugs both act by either stimulating or blocking receptors of autonomic nervous system. Here is a list of some cholinergic agonists, which includes direct acting, indirect acting, reversible, indirect acting, irreversible, reactivation of acetylcholinesterase. Direct acting include acetylcholine, bethanyl, carbachol, cevimeline, and pilocarpine, while indirect acting include ambinonium, donepezil, galantamine, neostigmine, physostigmine, pyridostigmine, rivastigmine, and tacrine. Indirect acting include ecothiophyte. Reactivation of acetylcholinesterase include pralidoxime. Now I move toward the cholinergic neuron. As we know that the preganglionic fibers terminate in the adrenal medulla, the autonomic ganglia, which includes both parasympathetic and sympathetic, the postganglionic fibers of the parasympathetic division use acetylcholine as a neurotransmitter. Also, the postganglionic sympathetic division of the sweat glands use acetylcholine. In addition, cholinergic neurons innervate the muscles of the somatic system and also play an important role in the central nervous system. What should we keep in mind? Patients with Alzheimer's disease have a significant loss of cholinergic neurons in the temporal lobe and entorhinal cortex. Most of the drugs available to treat the disease are acetylcholinesterase inhibitors. Next, I have neurotransmission at cholinergic neurons. In this, six sequential steps are involved. Number one, synthesis. Number two, storage. Number three, release. Number four, binding of the acetylcholine to a receptor. Number five, degradation of neurotransmitter in the synaptic cleft. That is the space between the nerve ending and adjacent receptors located on the nerves or effector organs. And number six, recycling of the choline and acetate. What is synthesis of acetylcholine? Choline is transported from extracellular fluid into the cytoplasm of the cholinergic neuron by an energy dependent carrier system that co-transports sodium and can be inhibited by the drug hemicholine. The uptake of choline is the rate limiting step in the acetylcholine synthesis. Choline acyl transferase catalyzes the reaction of choline with acyl coenzyme A to form acetylcholine in the cytosol. Acetyl or acyl coenzyme is derived from the mitochondria and is produced by the pyruvate oxidation and fatty acid oxidation. Second step that I have is the storage of acetylcholine in vesicles. The acetylcholine is packed or packaged and stored into presynaptic vesicles by an active transport process coupled to the efflux of proton. The mature vesicles contain not only acetylcholine but also adenosine triphosphate and proteoglycan. ATP has been suggested to be a co-transmitter acting at prejunctional purinergic receptors to inhibit the release of acetylcholine or norepinephrine. Co-transmission from autonomic neuron is the rule rather than the exception. This means that most synaptic vesicles will contain the primary neurotransmitter as well as co-transmitter that will increase or decrease the effect of the primary neurotransmitter. The neurotransmitters in the vesicles appear as bed-like structures known as pericocytes along the nerve terminal of the presynaptic neuron. Now, third, we have release of acetylcholine when an action potential propagated by voltage sensitive sodium channels arrives at a nerve ending. Voltage sensitive calcium channels on the presynaptic membrane open, causing an increase in the concentration of intracellular calcium. Elevated calcium levels promote the fusion of synaptic vesicles with the cell membrane and the release of their contents into the synaptic space. This release can be blocked by botulinum toxin. In contrast, the toxin in black widow spider venom causes all the acetylcholine stored in the synaptic vesicles to empty into the synaptic gap. Now I move toward the fourth step, that is binding to the receptor. Acetylcholine released from the synaptic vesicles diffuses across the synaptic space and binds to either of two postsynaptic receptors on the target cell, two presynaptic receptors in the membrane of the neuron that release the acetylcholine, or to other targeted presynaptic receptors. The postsynaptic cholinergic receptors on the surface of the effector organs are divided into two classes. These are muscarinic and nicotinic. Binding to a receptor leads to a biologic response within the cell, such as the initiation of a nerve impulse in a postganglionic fiber or activation of specific enzyme in effector cells as mediated by second messenger molecule. Now, fifth step I have, that is degradation of acetylcholine. The signal at the post-junctional effector site is rapidly terminated because acetylcholinesterase cleaves acetylcholine to choline and acetate in the synaptic cleft. Now the last step is the recycling of choline, that is choline may be recaptured by sodium coupled high affinity uptake system that transport the molecule back into the neuron. There it is acylated into acetylcholine that is stored until released by a subsequent action potential. Now I have cholinergic receptors. Two families of cholinereceptors designated muscarinic and nicotinic receptors that can be distinguished from each other on the basis of their different affinities for agents that mimic the action of acetylcholine. Muscarinic receptors belong to the class of G protein coupled receptors. These receptors, in addition to binding acetylcholine, also recognize muscarine, an alkaloid that is present in certain poisonous mushrooms. By contrast, the muscarinic receptors show only a weak affinity for nicotine. Binding studies and specific inhibitors, as well as cDNA characterization, have distinguished five subclasses of muscarine receptors: M1, M2, M3, M4, M5. Although the five muscarinic receptors have been identified by gene cloning, only M1, M2, and M3 receptors, which are functionally characterized. What is the location of muscarinic receptors? These receptors have been found on ganglia of the peripheral nervous system and on the autonomic effector organs such as heart, smooth muscle, brain, and exocrine glands. Specifically, although all five subtypes have been found on the neurons, M1 receptors are also found on the gastric parietal cells, M2 receptors on the cardiac cells and smooth muscles, and M3 receptors on the bladder, exocrine gland, and smooth muscle. What should we keep in mind? The drugs with muscarinic action preferentially stimulate muscarinic receptors on these tissue, but at high concentration they may show some activity at nicotinic receptors. Now we move towards the mechanism of acetylcholine signal transduction. A number of different molecular mechanisms transmit the signal generated by acetylcholine. Occupation of the receptor, for example, when the M1 or M3 receptors have activated, the receptor undergoes a conformational change and interact with the G protein designated GQ that in turn activates phospholipase C1. This leads to the hydrolysis of phosphatidylcholine inositosol 4,5 biphosphate to yield diacylglycerol and inositosol 1,4,5 triphosphate. Both inositosol 1,4,5 triphosphate and diacylglycerol are second messengers. Inositosol 1,4,5 triphosphate causes an increase in the intracellular calcium ion. This cation can then interact to stimulate or inhibit enzymes or to cause hyperpolarization, secretion, or contraction. Diacylglycerol activates protein kinase C. This enzyme phosphorylates numerous proteins within the cell. In contrast, activation of M2 subtype on the muscle stimulates a G protein designated GI, which inhibits adenyl cyclase and increases potassium conductance. The heart responds with a decrease in a rate and force of contraction. Now I move towards the muscarinic agonists and antagonists. Attempts are currently underway to develop muscarinic agonists and antagonists that are directed against specific receptor subtypes. For example, pyrazipine, a tricyclic anticholinergic drug, has a greater selectivity for inhibiting M1 muscarinic receptors, such as in the gastric mucosa. At therapeutic doses, pyrazipine does not cause many of the side effects seen with the non-subtype specific drugs. However, it does produce a reflex tachycardia on rapid infusion due to block of M2 receptors in the heart. Therefore, the usefulness of pyrazipine as an alternative to proton pump inhibitors in the treatment of gastric and duodenal ulcer is questionable. Darifenacin is a competitive muscarinic receptor antagonist with a greater affinity for the M3 receptor than for the other muscarinic receptors. The drug is cast in the treatment of overactive bladder. What should we note? At present, no clinically important agents interact solely with the M4 and M5 receptors. Now I move towards the nicotinic receptors. These receptors, in addition to binding acetylcholine, also recognize nicotine but show only a weak affinity for muscarine. The nicotinic receptor is composed of 5 subunits and it functions as a ligand-gated ion channel. Binding of two acetylcholine molecule elicit a conformational change that allows the entry of sodium ions, resulting in the depolarization of the effector cell. Nicotine at low concentration stimulates the receptor and at high concentration block the receptors. Nicotine receptors are located in the CNS, adrenal medulla, autonomic ganglia, and the neuromuscular junction. Now I have moved toward the direct acting cholinergic agonists. Cholinergic agonists mimic the effects of acetylcholine by binding directly to cholinesterase. These agents may be broadly classified into two groups: cholinesterases or choline esters, which include acetylcholine and synthetic ester of choline, such as acarbachol and bethanechol. Naturally occurring alkaloids such as pilocarpine constitute the second group. All of the direct acting cholinergic drugs have longer duration of action than acetylcholine. Some of the more therapeutically useful drugs like pilocarpine and bethanechol preferentially bind to muscarinic receptors and are sometimes referred to as muscarinic agents. Note: muscarinic receptors are located primarily but not exclusively at the neuroeffector junction of the parasympathetic nervous system. However, as a group, the direct acting agonists show little specificity in their action, which limits their clinical usefulness. Now, first we have acetylcholine. Acetylcholine is a quaternary ammonium compound that cannot penetrate membranes. Although it is a neurotransmitter of parasympathetic and somatic nerves as well as autonomic ganglia, it lacks therapeutic importance because of its multiplicity of action and its rapid inactivation by the cholinesterase. Acetylcholine has both muscarinic and nicotinic activity. Its action include decrease in heart rate and cardiac output and decrease in blood pressure and some of other actions. How it act in decrease in heart rate and cardiac output? The action of acetylcholine on the heart mimic the effect of the vagal stimulation. For example, if injected intravenously, acetylcholine produces a brief decrease in cardiac rate and stroke volume as a result of the reduction in the rate of the firing at the sinoatrial node. Next, we have decrease in the blood pressure. Injection of acetylcholine causes vasodilation and lowering of blood pressure by an indirect mechanism of action. Acetylcholine activates M3 receptors found on the endothelial cell lining the smooth muscles of the blood vessels. This results in the production of nitric oxide from arginine. Nitric oxide then diffuses to vascular smooth muscle cells to stimulate protein kinase G production, leading to hyperpolarization and smooth muscle relaxation via phosphodiesterase 3 inhibition. In the absence of administered cholinergic agent, the vascular receptors have no known function because acetylcholine is never released into the blood in any significant quantities. Atropine blocks these muscarinic receptors and prevents acetylcholine from producing vasodilation. What other actions performed by acetylcholine? In the gastrointestinal tract, acetylcholine increases salivary secretion and stimulates intestinal secretion and motility. It also enhances bronchiolar secretion. In the eye, acetylcholine is involved in stimulating ciliary muscles or ciliary muscles contraction for near vision and in the constriction of the pupillae sphincter muscle, causing meiosis. Acetylcholine 1% solution is instilled into the interior chamber of the eye to produce meiosis during ophthalmic surgery. Now I move toward the second classification, that is bethanechol. Bethanechol is an unsubstituted carbamyl ester structurally related to acetylcholine in which the acetate is replaced by carbamate and the choline is methylated. Hence, it is not hydrolyzed by acetylcholine esterase due to the esterification of carbamic acid, although it is inactivated through hydrolysis by other esterases. It lacks nicotinic actions due to the addition of the methyl group but does have strong muscarinic activity. Its major actions are on the smooth musculature of the bladder and GI tract. It has about 1 hour duration of action. What is the action of bethanechol? Bethanechol directly stimulates muscarinic receptors, causing increased intestinal motility and tone. It also stimulates the detrusor muscles of the bladder, whereas the trigone and sphincter are relaxed. These effects increase voiding pressure and decrease bladder capacity to cause expulsion of urine. Now, what are the therapeutic application of bethanechol? In urologic treatment, bethanechol is used to stimulate the atonic bladder, particularly in the postpartum or post-operative non-obstructive urinary retention Bethanechol may also be used to treat neurogenic atony as well as megacolon. Now, what are the adverse effects of bethanechol? Bethanechol causes the effects of generalized cholinergic stimulation. These include sweating, salivation, flushing, decreased blood pressure, nausea, abdominal pain, diarrhea, and bronchospasm. Atropine sulfate may be administered to overcome severe cardiovascular or bronchoconstrictor responses to this agent. Now I move towards the carbachol or carbamylcholine. Carbachol has both muscarinic as well as nicotinic action. It lacks the methyl group present in the bethanechol. Like bethanechol, carbachol is an ester of carbamic acid and a poor substrate for acetylcholinesterases. It is a biotransformed by other esterases but at a much slower rate. What is the action of carbachol? Carbachol has profound effect on both the cardiovascular and GI systems because of its ganglion stimulating activity, and it may first stimulate and then depress these systems. It can cause release of epinephrine from the adrenal medulla by its nicotinic action. Locally instilled into the eye, it mimics the effect of acetylcholine, causing meiosis and a spasm of accommodation in which the ciliary muscles of the eye remains in a constant state of contraction. Now, what are the therapeutic uses of carbachol? Because of its high potency, receptor non-selectivity, and relatively long duration of action, carbachol is rarely used therapeutically except in the eye as a miotic agent to treat glaucoma by causing pupillary contraction and a decrease in intraocular pressure. Onset of action for meiosis is 10 to 20 minutes. Intraocular pressure is reduced for 4 to 8 hours. Now, what are the adverse effects of carbachol? At doses used ophthalmologically, little or no side effects occur due to the lack of systemic penetration. Next, we have pilocarpine. The alkaloid pilocarpine is a tertiary amine and is stable to hydrolysis by acetylcholinesterase. Compared with acetylcholine and its derivatives, it is a far less potent but is uncharged and will penetrate the central nervous system at therapeutic doses. Pilocarpine exhibits muscarinic activity and is used primarily in ophthalmology. What is the action of pilocarpine? Applied topically to the cornea, pilocarpine produces rapid meiosis and contraction of the ciliary muscles. When the eye undergoes this meiosis, it experiences a spasm of accommodation. The VN becomes fixed at some particular distance, making it impossible to focus. Pilocarpine is one of the most potent stimulator of secretion such as sweat, tears, and saliva, but its use for producing these effects has been limited due to its lack of selectivity. The drug is beneficial in promoting salivation in patients with xerostomia resulting from irradiation of the head and neck. Sjogren's syndrome, which is characterized by dry mouth and lack of tears, is treated with oral pilocarpine tablets and cevimeline, a cholinergic drug that also has the drawback of being non-specific. Now I move towards the therapeutic use of pilocarpine in the glaucoma. Pilocarpine is used to treat glaucoma in the drug of choice in the emergency lowering of intraocular pressure of both narrow angle and wide angle glaucoma. Pilocarpine is extremely effective in opening the trabecular meshwork around Schlimm's canal, causing an immediate drop in intraocular pressure as a result of the increased drainage of aqueous humor. This action occurs within a few minutes, lasts 4 to 8 hours, and can be repeated. The organophosphate ecothiophyte inhibits acetylcholinesterase and exerts the same effect for a longer duration. Note: carbonic anhydrase inhibitors such as acetazolamide as well as the beta-adrenergic blockers timolol are effective in treating chronic glaucoma but are not used for emergency lowering of intraocular pressure. The meiotic action of pilocarpine is also useful in reversing mydriasis due to atropine. Now, what are the adverse effects of the pilocarpine? Pilocarpine can enter the brain and cause central nervous system disturbances. Poisoning with this agent is characterized by exaggeration of various parasympathetic effects, including profuse sweating and salivation. The effects are similar to those produced by consumption of mushrooms of the genus Inocybe. Parenteral atropine at doses that can cross the blood-brain barrier is administered to counteract the toxicity of pilocarpine. Now I move toward the second classification, that is indirect acting cholinergic agonists, which includes reversible acetylcholinesterase inhibitors. Acetylcholinesterase is an enzyme that specifically cleaves acetylcholine to acetate and choline and thus terminates its action. It is located both pre and post synaptically in the where it is membrane bound. Inhibitors of acetylcholinesterase indirectly provide a cholinergic action by prolonging the lifetime of acetylcholine produced endogenously at the cholinergic nerve endings. This results in the accumulation of acetylcholine in the synaptic spaces. Therefore, these drugs can provoke a response at all cholinergic receptors in the body, including both muscarinic and nicotinic receptors of the autonomic nervous system as well as at neuromuscular junction and in the brain. The reversible acetylcholinesterase inhibitors can be broadly classified as short acting or intermediate acting agents. Adrophonium, which is one of indirect acting cholinergic agonists. Adrophonium is a prototype short-acting acetylcholinesterase inhibitor. Adrophonium binds reversibly to the active center of the acetylcholinesterase, preventing hydrolysis of acetylcholine. It is rapidly absorbed and has a short duration of action of 10 to 20 minutes due to rapid renal elimination. Adrophonium is a quaternary amine and its action are limited to the periphery. It is used in the diagnosis of myasthenia gravis, which is an autoimmune disease caused by antibodies to the nicotine receptor at neuromuscular junctions. This causes their degradation, making fewer receptors available for interaction with the neurotransmitter. Intravenous injection of adrophonium leads to a rapid increase in the muscle strength. Care must be taken because excess drug may provoke a cholinergic crisis in which atropine is the antidote. Adrophonium may also be used to assess cholinesterase inhibitor therapy for differentiating cholinergic and mesenteric crisis and for reversing the effect of non-depolarizing neuromuscular blocker after surgery. Due to the availability of other agents, adrophonium use has become limited. Now we move towards the second classification, that is physostigmine. Physostigmine is a nitrogenous carbamic acid ester found naturally in the plants and is tertiary amine. It is substrate for acetylcholinesterase and it forms a relatively stable carbomylated intermediated with the enzyme, which then becomes reversible inactivated. The result is potentiation of cholinergic activity throughout the body. What is the action of physostigmine? Physostigmine has a wide range of effects as a result of its action and stimulates not only the muscarinic and nicotinic sites of the autonomic nervous system but also the nicotinic receptors of the neuromuscular junction. Its duration of action is about 2 to 4 hours and it is considered to be an intermediate acting agent. Physostigmine can enter and stimulate the cholinergic sites in the central nervous system. Now we move towards the therapeutic uses of physostigmine. The drug increases intestinal and bladder motility, which serve as its therapeutic action in atony of either organ. Placed topically in the eye, it produces meiosis and spasm of accommodation as well as lowering of intraocular pressure. It is used to treat glaucoma, but pilocarpine is more effective. Physostigmine is also used in the treatment of overdoses of drugs with anticholinergic action such as atropine, phenothiazines, and tricyclic antidepressants. What are the adverse effects of physostigmine? The effects of physostigmine on the central nervous system may lead to convulsion when high doses are used. Bradycardia and a fall in the cardiac output may also occur. Inhibition of acetylcholinesterase enzyme at the skeletal neuromuscular junction causes the accumulation of acetylcholine and ultimately result in the paralysis of the skeletal muscle. However, these effects are rarely seen with therapeutic doses. Now we move towards the neostigmine. Neostigmine is synthetic compound that is also a carbamic acid ester and is reversibly inhibits acetylcholinesterase in a manner similar to that of the physostigmine. What is the action of neostigmine? Unlike physostigmine, neostigmine has a quaternary nitrogen, therefore it is more polar, it is absorbed poorly from the GI tract and does not enter the central nervous system. Its effect on the skeletal muscle is greater than that of physostigmine and it can stimulate contractility before it paralyzes. Neostigmine has an intermediate duration of action, usually 30 minutes to 2 hours. What is the therapeutic uses? What are the therapeutic uses? It is used to stimulate the bladder and GI tract as an antidote. Neostigmine is also used symptomatically to treat myasthenia gravis. Neostigmine and other acetylcholinesterase enzyme inhibitors preserve endogenous acetylcholine, which can stimulate a greater number of acetylcholine receptors at the muscle end plate. What are the adverse effects of the neostigmine? Adverse effects of neostigmine include those of the generalized cholinergic stimulation such as salivation, flushing, decreased blood pressure, nausea, abdominal pain, diarrhea, and bronchospasm. Neostigmine does not cause central nervous system side effects and is not used to overcome toxicity of central acting antimuscarinic agents such as atropine. Neostigmine is contraindicated when intestinal or urinary bladder obstruction is present. It should not be used for patients who have peritonitis or inflammatory bowel disease. Next classification we have pyridostigmine and embinonium. Pyridostigmine and embinonium are other cholinesterase inhibitors that are used in the chronic management of myasthenia gravis. Their duration of action are intermediate. Pyridostigmine lasts for 3 to 6 hours while embinonium lasts for 4 to 8 hours but longer than that of neostigmine. Adverse effects of these agents are similar to those of neostigmine. Next we have tacarine, danepezil, rivastigmine and galantamine. Patients with Alzheimer's disease have a deficiency of cholinergic neurons in the CNS. This observation lead to the development of anticholinesterases as possible remedies for the loss of cognitive function. Tacarine was the first to become available, but it has been replaced by other because of its hepatotoxicity. Despite the ability of danepezil, rivastigmine, and galantamine to delay the progression of Alzheimer's disease, none can stop its progression. GI distress is their primary adverse effects. Next, we have indirect acting cholinergic agonists, which includes anticholinesterase irreversible. A number of synthetic organophosphate compounds have the capacity to bind covalently to acetylcholinesterase. The result is a long-lasting increase in acetylcholine at all sites where it is released. Many of these drugs are extremely toxic and were developed by the military as nerve agents. Related compounds such as parathion are used as insecticides. Now we move towards ecothiophyte. Ecothiophyte is an organophosphate that covalently binds via its phosphate group to the serine hydroxyl group at the active site of acetylcholinesterase. Once this occurs, the enzyme is permanently inactivated, and restoration of acetylcholinesterase activity requires the synthesis of new enzyme molecule. Following covalent modification of acetylcholinesterase, the phosphorylated enzyme slowly releases one of its ethyl groups. The loss of an alkyl group, which is called aging, makes it impossible for chemical reactivators such as pralidoxime to break the bond between the remaining drug and the enzyme. Now, what is the action of ecothiophyte? Actions include generalized cholinergic stimulation, paralysis of motor function, causing breathing difficulties and convulsion. Ecothiophyte produces intense meiosis and thus has found therapeutic use. Intraocular pressure falls from the facilitation of outflow of aqueous humor. Atropine in a high dosage can reverse many of the muscarinic and some of central effect of ecothiophyte. Now move towards the therapeutic uses of ecothiophyte. An ophthalmic solution of the drug is applied topically to the eye for the chronic treatment of open angle glaucoma. Ecothiophyte is not a first line agent in the treatment of glaucoma. In addition to its other side effects, the potential risk of causing cataracts limits its use. Now we have the toxicology of cholinesterase inhibitors. Acetylcholinesterase inhibitors are commonly used as agriculture insecticides in the United States, which has led to the numerous cases of accidental intoxication with these agents. In addition, they are frequently used for suicidal and homicidal purposes. Toxicity with these agents is manifested as nicotinic and muscarinic signs and symptoms. Depending on the agent, the effects can be peripheral or effect or affect the whole body. Reactivation of cholinesterase. Pralidoxime can reactivate inhibited acetylcholinesterase. However, it is unable to penetrate into the central nervous system. The presence of charged group allows it to approach an anionic site on the enzyme where it essentially displaces the phosphate group of the organophosphate and regenerate the enzyme. If given before aging of the alkylated enzyme occurs, it can reverse the effects of the ecothiophyte except for those in the central nervous system. With the newer nerve agents which produce aging of the enzyme complex within seconds, pralidoxime is less effective. Pralidoxime is a weak acetylcholinesterase inhibitor and at higher doses may cause side effects similar to other acetylcholinesterase inhibitors. In addition, it cannot overcome toxicity of reversible acetylcholinesterase inhibitor, for example, physostigmine. Other treatment. Atropine is administered to prevent muscarinic side effects of these agents. Such effects include increased bronchial secretion and saliva, bronchoconstriction, and bradycardia. Diazepam is also administered to reduce the persistent convulsion caused by these agents. General supportive measures such as maintenance of patent airway, oxygen supply, and artificial respiration may be necessary as well. Here I conclude my topic. I hope you like it. For more information, like and subscribe my channel. Thank you.